I'll wait for you to finish playing.
Hello and welcome to this evening's webinar, IVF at Therapy Fertility and knowing when to start IVF. My name is Ranae van Medyen and I'll be hosting this evening's event. I'm delighted to be joined tonight by our medical director, Dr. John Kennedy.
Evening.
And for the next 40 minutes or so, we'll be talking you through treatment in therapy fertility with, of course, a particular focus on knowing when it's time to start having these conversations about starting fertility treatment. Before we get started, I'd like to remind you that you can ask any questions throughout the webinar, which we will do our best to answer at the end. And if you have any additional questions after the event has ended, please do feel free to send in questions via our social channels. So let's get right to it.
Get into it.
So for anyone who's watching, I'm sure everyone knows who you are, but some may not. Okay. So maybe you could just tell us a bit about yourself.
So John Kennedy, I'm the medical director, as you said, in therapy fertility. I've got qualified as a doctor 22 odd years ago. I worked in obstetrics and gynecology around Ireland for many years until about 2012. Then I moved into fertility and I've been working exclusively in fertility since 2012. We started Therapy Fertility and we opened in July of last year. I really should know the date off the top of my head, but I don't.
21st.
21st, yeah, remember the 21st when we opened. And we've been going gangbusters. So I've been working purely in IVF and fertility, well, fertility per se, for a number of years. Pretty passionate about it. And I'm delighted to be part of this because I think what we're doing here is genuinely different, and it's a new way of accessing care and giving people the opportunity to have children and families.
So what does make therapy different?
I mean, different, like it's doing the same things that other fertility clinics do. There's no magic potion that suddenly makes fertility more or less successful, but fertility, and especially IVF, is very much an established field now. For years it was a little bit out in the wilderness. Loads of people were doing different things, and the difference between a good IVF clinic or a good lab and a bad lab was night and day, and massive differentials in success rates. But modern technologies have come into play a lot more. We've got time-lapse incubators for storing embryos. We've got standardized media for the little fluid that the eggs, the sperm, and the embryos sit and gestate in. And it's all been much more process flow and driven, and it's not as unique and bespoke as it used to be. With that comes the opportunity to make things more accessible and affordable. You can, if you have a streamlined process and it's cheaper to deliver that streamlined process, both at all aspects of care, in terms of patient interactions, in terms of care delivery, in terms of egg collections, embryology, embryo transfer, then you can pass that on to the end user, the patient, and you can, for want of a better word, just provide it more cheaply. And so that's what we're doing. We're making fertility treatments more accessible and more affordable because, well, we know, listen, this is nothing new, that Ireland is one of the very few countries that's left in the developed world that doesn't have a publicly funded IVF system. In the absence of that, all of us, I think, who work in this field know that we are not managing our infertile and subfertile population well in this country. Yeah. I think there's an awful lot of women and couples out there who are remaining childless because they simply can't afford or access treatment. Yeah. So giving people the opportunity to do that, I'm not saying it's free, there's still a cost to it, but making it far more accessible is going to widen the number of people who can have fertility treatment. And look, I also like to think that we're brilliant at what we do. I'm going to always say that, I'm biased, but we've built something from scratch. So we've built a really, really good lab. It's not all about, I wish it was all about me. It's not all about me. It's about the lab environment. It's about the embryologist, and building that from scratch and having no legacy issues and just starting clean. Very easy. Makes life so much simpler for us. And we're able to kind of deliver better care, better outcomes more affordably. I mean, I genuinely believe that, which is great.
And I think that comes across. That's one thing people constantly say to me is that, you know, you in particular, I don't want to give you a bigger, ego. Yeah. Don't need it. No, but come across as authentic and genuine, and genuinely, honestly believe in what you're doing.
Oh yeah, no, I mean, this is great. Look, I've always believed in fertility care, and I've always believed in helping people, and it's a big part of who I am, and as I say, ego and all the rest. But to be able, this what we're doing now is going to change everything. This is going to be, I believe, the new model for how fertility care should be delivered in the private healthcare context, in the context of private healthcare. Or if you are building a public system, swear to God, if you are building a public system for delivering fertility care tomorrow, you should look at our model. Genuinely, you should look at that and just copy that, because it is the most efficient way to deliver the maximal results that you possibly can. You're not compromising on outcomes. You're delivering really proper world-class care, but you're trying to do it affordably.
Yeah.
So this should be the model for how care is delivered, not just in Ireland, but abroad. I think fertility has been the enclave of a bunch of smaller organizations, all of whom are doing their own thing, and a lot of whom have legacy issues abroad, everywhere. And there's a real opportunity to start from a fresh perspective and do it efficiently.
Okay, so let's talk about when people need to start talking about fertility treatment, because obviously there's people like myself who may be in a same-sex couple and they are going to need donor sperm to conceive, or someone who wishes to become pregnant solo, so in those situations, it's kind of obvious that when you want to have a baby, you're going to need to come and talk to someone like you.
For sure. I mean, look, there's the safe answer, and the safe answer is the World Health Organization, which says subfertility and fertility is a disease. It's defined as not achieving a pregnancy within a year of trying if you're under 35, and within 6 months of trying if you're over 35. And that's the answer that tends to get trotted out an awful lot. I would very much like to change that narrative. And I think it should be split into a number of different cohorts. I think people, tragically, especially women, should be fertility aware before they are trying to conceive. This is a bugbear. So I think fertility assessment is something that should be undertaken by all people, ideally, probably at some point from the age of 25 onwards.
So like having a smear or...
And that's why I picked that age. At the time, ideally you should start having your smear tests when you become sexually active, but we acknowledge that the rates of cervical cancer are not zero, but very low in the 18 to 25 group. So it's reasonable and fiscally correct and economically responsible to maybe think about starting smears at 25. The proportion of people who are going to have fertility issues at between 25 and 30 is very, very low. But equally, and I'm biased, declare that, equally, that the people who do have fertility issues at that age, they really should know at that time, because that'll give them agency and ownership over the consequences of that and what options they may have, which may time out faster than everybody else. So I think when you should seek help is a different conversation to when should you start being fertility aware. So I'm a big fan of semen analysis at a young age, AMH ovarian reserve check at a young age. Now, if you haven't done all that and you're starting to try to conceive, by all means, give yourself a few months. No question about it. Just try. If you're over the age of 35, I think what you can do is have a brief conversation with your partner where you go, assuming a heterosexual relationship, look, we're going to give this till April or March or June or whenever. And at that point, if nothing happens, listen, we'll go and we'll get checked. And that'll make getting to that point an awful lot easier. Having a plan, a logical step, but having sex for reproductive purposes is no fun. It stops being fun virtually immediately. So having that, look, we know if this doesn't happen, then we'll do this, makes getting to that point potentially an awful lot easier. So
what do you think, if people did start getting checked earlier, if the way we view fertility and infertility and subfertility changed from a young age, that if we started learning about it in schools, what would that do? What would that achieve?
Well, the first, I think it would achieve a couple of different things. We know the average age in 2021 that women are getting married is now in Ireland is 35. I think families are still starting at around an average of 32, 33. We know at that age, a higher proportion of people are going to run into problems. That's just the statistical norm. 1 in 4, 1 in 5 couples will struggle a little bit. People equate having fertility investigations with having a disease or needing treatment. That's what I want to try to kind of separate out a little bit. So at a younger age, get checked. If everything's normal and you don't want to conceive, sayonara, off you go, off into the wilderness, maybe get rechecked in a year or two. If you think, right, I'm in my early 30s and I know I don't want to have children for many years to come because of a variety of different reasons, then fine, just consider maybe egg freezing or something like that, or embryo freezing. I think it's something that's becoming a bit more popular. And you're just giving yourself options and a plan B. Equally, if you are trying to conceive, there's probably not really too early a time to get checked. If you come in and you see me and you've been trying for 2 months to get pregnant and all your tests are normal and there's no problems and you're young and you're healthy, I'm going to tell you to go away. I'm not going to upsell you into, oh, you need to do IVF right now. Of course you don't. What you do need to understand is, what are the percentage chances of you getting pregnant yourself any given month? What are your percentage chances of success with fertility treatments? And how much effort do you want to put into it versus how quickly you want to get across to the other side? Usually you don't need to do anything and off you go. And look, if nothing's happened, we'll see you in 6 months. And we'll talk about it then, and you'll have an awareness of what this might look like. And with a bit of luck, I see loads of those people, and most of them I never see again because they go off and they get pregnant spontaneously. Great. But it does mean that if they are one of the cohort who runs into a problem, then you've got ahead of it a little bit. You know what the tests are, and it makes those conversations an awful lot easier to have and to hear as well.
So with a lot of the people that you're seeing now, heterosexual couples we're talking here, how many of them do you think, if they rewound the clock 10 years and knew
that's a dirty question.
And had some information about,
that's a dirty question. So
but could anything have been done to alter the course of the last 10 years, or would they have ended up
10 years is a long time. So you'd be hard put to give two age ranges. Maybe 20 and 30 would be more similar, but there's a massive fertility difference between the 30 and the age of 40. Massive. So, I mean, if you ask, like, the children born of fertility treatment will be the most fertility aware group of people in the world. All right. Yeah. That tells you something straight away, that they're going to be fertility aware. They're going to have it drilled into them in an early stage that this is something you want to be on top of. If we can spare you what we had to go through, because fertility treatment ain't easy, then we will. So that's the common thread. I wish I had started earlier. I wish I'd engaged earlier. Not always. Some people come in very quickly, but it is something we want to see more of, not less of. And I still see a regrettable number of people, and I think maybe I'm seeing more with our thing now, because they can finally get access, they can finally become achievable and affordable, who have been trying a depressingly long period of time. Like somebody who's 35 years old, we've been trying for 10 years. That's a gut punch. That's really upsetting. It's really upsetting to see, oh my God, because that's 10 years. That's 10 years of being told, relax, it'll happen. 10 years of platitudes from friends. 10 years of seeing everybody around you have children and get married and evolve their lives in exactly the kind of way that you want to. And that's kind of heartbreaking. And you only hope that at that point that you've got a problem you can fix and get them across the line.
If someone has been trying, should they come to a fertility clinic as a first protocol, or should they have a conversation with a GP or some other fertility specialist?
Look, I mean, this sounds like I'm being down on GPs, and I'm not. I think there's lots of really excellent GPs who live in the fertility space very, very capably, but equally there's a lot out there who don't. So if you're doing a fertility assessment, you need to check the egg, the sperm, and the housing. That's it. So
I love when we call it housing.
Sorry, yeah, it's a technical term. You'll find it in the textbooks. Sperm is a semen analysis. Womb assessment. There's lots of different ways of doing it. It's not for everybody. You might actually need it. It might be simpler to do a simple ultrasound scan. The one blood test you need is an AMH, anti-Mullerian hormone. I'm sure everybody's watching this is super familiar with this. It's a test of how many apples are left in the barrel. It's egg quantity. It's not egg quality. The problem is an awful lot of primary care physicians and GPs don't do AMH. What they do is day 21 progesterone. So the most common test you see done for fertility workup in the community, your standard bloods, your thyroids, prolactins, testosterone, and whatnot. But then you'll also see FSH, which is nice, but if your FSH is high, there's a whole bunch of different problems there. It's not a reliable index of ovarian reserve. you'll see estradiol, which is pure meaningless because it varies throughout the cycle. And you see day 21 progesterone, which is the test to see if you've ovulated 7 days earlier. It is literally the purest example of closing the door after the horse has bolted. So knowing you ovulated a week ago is no help to anybody. 80 to 85% of people who have regular cycles are ovulating. So you don't need that information. You can take it as read. And knowing that you ovulated the previous month, there's no guarantee that you're ovulating the next month. So people come in clutching this test going, I've had my, it's not a test I ever do myself. So there is a disconnect between what I do as a fertility workup and what's commonly done in GP practices. Not always, some of them are brilliant, but it's a bit hit and miss.
So perhaps you would lean towards going to a specialist.
I would. I mean, look, again, our model is you get a nurse consultation. It doesn't cost you a penny.
It's free,
Why
yeah.
not?
Yeah.
I mean, what's the downside? That's cheaper than the $65 you're going to pay your GP. Go and have a conversation. Yeah. I mean, a proportion of patients who come in to see our nurses don't ever go on to have treatment. And a chunk of them are people we're telling not to go on and have treatment. Yeah. That's okay. It's about building that awareness in the community and seeding those things so that the proportion of people who do run into problems later on have got a leg in already.
Here's a question. If you had a same-sex couple or indeed some just from the LGBTQ plus community who maybe kids weren't on their radar immediately. So say myself, for example, I always knew we'd need to conceive with the assistance of donor sperm, but I just assumed we'd have no fertility issues. Would you also would you have said to me, 10 years ago that I should go get tested as well?
I wouldn't have said it 10 years ago, but I'm saying it now. And that's the change that's happened in my ideology and my philosophy. And perhaps, again, I'm biased. Perhaps it's because I've seen nothing but problems day in, day out.
Yeah.
But you'll be fine in 6 months or it's a year. And, I suppose you'll need treatment with donor sperm. So come to us when you're ready to crack on, then we'll do the testing. But now I don't even see the world through that lens. You are a human being who at some point may want to have a family. You should get checked. Yeah. I mean,
regardless
gender
of how,
and sexual orientation shouldn't matter, right?
Just every person really should be getting checked.
Yeah.
If only they could work that into some sort of curriculum or...
there's a huge educational piece on this. It's got better. But we're still battling, not just with the lack of education at a young age about fertility. It's not just that there's a dearth of information there. It's that a lot of the information actively goes the other way. The pendulum is not just in the middle, it's actively on the wrong side. And it's telling people they get pregnant if you hang the trousers on the end of the bed and.
It's just totally crazy. We asked on our Instagram this week, we asked, did anyone learn about fertility in school? And if so, what did they learn? And I'm sure you can imagine the answers were pretty shocking, but it was pretty much, you'll get pregnant. Yeah. From anything. Don't get pregnant. Don't get pregnant. Don't have sex.
Don't get pregnant.
Absolutely.
Oh, you're asked about fertility. Let me tell you about STDs. No, that's not the question I asked.
No one learned anything about what happens when you can't get pregnant.
So again, I've been shouting into an echo chamber. This forum, these formats allow us maybe to try to start to reach a wider audience and just get the awareness up.
Yeah. So actually what we're going to do now is jump straight into questions because at our last webinar, so many questions came in that we didn't get to all of them. And actually a lot of these questions are talking about when is it time.
So for the record, I haven't seen these. These are cold. Ranae usually screens them, but not always.
I thought it'd be more fun as a surprise.
Okay, here we go.
Okay. Would you recommend IVF for a short luteal phase of 7 days or less?
Okay, so short luteal phase or progesterone deficiency in the luteal phase progesterone deficiency. It's pretty controversial. So the first cycle is divided into two halves. First half is follicular phase, development of the follicle containing the egg, triggering the release of the egg, the surge in progesterone, and then the luteal phase as the womb gets ready to hold a pregnancy, or in the event that a pregnancy doesn't happen, sheds, and that's your period. Right. So if you have a progesterone deficiency, the lining collapses and you shed off before you're ready to, so you can give progesterone to support that. It's a tricky thing to diagnose because you ovulate or you get your period 2 weeks after you ovulate. usually. So if you've got a 28-day cycle, that's smack bang in the middle. If you've got a 35-day cycle, it's probably later. If you've got a shorter cycle, it might be that your luteal phase is deficient, but it might be that you ovulated early as well. So unless you're exactly pinpointing ovulation, and you're not going to do that with blood tests, really, the best way to do that is with scans and triggers. It can be done with blood tests, but it's messy. It's hard to know if you have a luteal phase deficiency or not. So what you wind up with is an awful lot of women getting progesterone who don't actually need it. Now, that is not to say there are not people out there who need progesterone support in the back half of a cycle, but the number is a hell of a lot smaller than the people who are getting progesterone in the back half of the cycle. Do you need, in a fresh IVF cycle, and frozen embryo transfer, different story, in a fresh IVF cycle, do you need to give luteal support? Technically, no, you don't. You can get away without it. The body should produce its own progesterone. Do we give progesterone to everybody? Absolutely, we do. And my answer to that question is really unfair. Is what do you do for luteal phase deficiency? As like, if you're having treatment with me, any kind of treatment role, I'm giving you progesterone support. So I don't even have to think about the answer to that question, because the answer to that question out in the community is actually really, really messy. So there is definitely a space for it in the context of ovulation induction cycles and if people have irregular cycles. But if you can get people ovulating regularly, generally the back half of the cycle looks after itself, but not always.
Okay. Does having long COVID affect my chances of IVF, of being successful at IVF?
So how does COVID affect the menstrual cycle? How does the COVID vaccine affect the menstrual cycle? There's growing data on this, and ask me again next week. My opinion might be different. If you'd asked me 6 months to a year ago, I would have said, look, there's no evidence that the vaccine or COVID impacts the menstrual cycle. There's a growing body of evidence, and certainly anecdotally, it's something I would have seen a lot over the last year. People saying, my cycle became disordered after I had the vaccine. My cycle became disordered after I got COVID. Certainly the impact on menstruation seems to be worse with COVID than with the vaccine. So that's good news. The big trial that was done on the impact on menstruation showed that it was very short and transient. There's an awful lot of women out there who would disagree with that and say it takes a couple of months and it can be worse than that. So the jury's still a little bit out on that, but it does seem to correct itself. Aside from that disruption to the cycle, it does not appear at this point that either COVID or the vaccine has an impact on fertility as such. On the ovulation of those cycles, yeah, granted, but long-term, no. Now, long COVID is something that we know frighteningly little. So it seems to be multi-organ, it seems to be systemic. It seems to be reasonable to posit that it may have an impact on fertility, but that is pure supposition. If you're worried about fertility and you have long COVID, then it should push you a little bit more to get checked and consider options, I would suggest. But I don't want to scaremonger, and I don't have any evidence that says that this is a problem. Okay.
I had a miscarriage a year ago, haven't been able to get pregnant since. Should I try IVF?
Okay, so I mean, there's a lot of information we don't have there: age, ovarian reserve, et cetera, et cetera. The first thing to say is statistically, that's not a bad thing to have a miscarriage. Obviously, it's horrendous to have a miscarriage. It's really, really upsetting. But if you've had a miscarriage, the three big takeaways that you need to hear, you need to believe, and you need to own are: one, miscarriages are very, very common. 1 in 4, 1 in 5 pregnancies, probably even higher if you go back earlier. That's of cold comfort to somebody who's gone through a miscarriage, but it does illustrate point 2. This is nothing they did or didn't do. I have yet to meet the woman who hasn't forensically dissected the weeks before a miscarriage to find something to blame themselves. It's very human. It's very normal. It's also wrong. You shouldn't do that. So the third thing to say is having a miscarriage doesn't mean you're more likely to have a miscarriage in the future. If you have multiple miscarriages, yes, that does have an impact, but having one doesn't so much. So when you've had a miscarriage, statistically, that tells me certain things are working. And it actually means that perhaps your chance with fertility treatment are better. Almost irrespective of the miscarriage is that this person has been trying for a year to conceive and hasn't got any success. So now is the time to start thinking about options. Yes, one way or the other.
Okay. How common are blighted ovums?
Okay, very. So, wow, talk about an appropriate question to segue into. Most miscarriages are due to chromosomal issues in the embryo. So the embryo stops developing, and you can get empty sacs or ovums that don't generate. That's where the vast majority of miscarriages come from. It's nature's way of sorting things out at an earlier stage, and the body just tidying things up. Obviously very, very upsetting. So as I said, 1 in 4, 1 in 5 pregnancies ends in miscarriage. I think possibly at a young age, if you were able to, I think 50% of embryos that are generated in vivo, in life, don't implant. And they don't even manifest as a miscarriage. They just die off before implantation or very shortly thereafter.
Okay. How old is too old?
Oh, God.
Not in general, for IVF.
So success rates, you tend to hold them 34 to 35 years old. 35 to 40 is when they drop. So without, and people are going to hear this and you're going to run off down the street with this data, and it's very broad, very generalized. Take home baby rate with the cycle of IVF age 35 is probably in the order of 40 to 50%, maybe even a little higher. At 40 years old, it's 20 to 23% maybe. At 41 years old, it drops to about 15. At 42, 12. At 43, 8. At 44, you're kind of into 4%. At 45, you're down to 1 to 3%. So how old is too old? Have I looked after people this age and older? Yeah, absolutely, I have. It's a question of understanding. It's a question of counseling. It's a question of consent, people understanding what the chances are. And those numbers are dropped because the risk of miscarriage goes up as you get older. And so that's one of the big key things that we can't really do a whole lot about. So you're not too old to do IVF. You're not too old to have a conversation. But if you're talking to somebody who has your best interests at heart, they will be blunt. There's kind ways of being blunt and there's perhaps unkind ways of being blunt. But the message has to be gotten across that I don't tell people what to want, but they need to understand what 1% chance of success means. It means that you need to do this 100 times, and you're not going to do it 100 times, which means you need to be massively lucky to do it once. Pregnancies happen spontaneously in those ages out of the community. We talk about them a lot, but in fertility, they're rare. The oldest recorded success with own egg in IVF is at 46 years old, but that's a limit, not a target. So the oldest person I've ever had success, I think, was 44, 45.
Okay. Good question next. I'm turning 40 this year. AMH of 3.9, have been advised by fertility clinic to do IVF straight away. My partner is reluctant to do it. I'm also unsure. I'm wondering, is it even worth trying IUI first, or would that give any greater chance of conceiving than trying naturally? So
more bias. If the sperm is normal, the tubes are open, you're ovulating, it's hard to see how much bang for your buck IUI offers you. It might kick up your percentage. For those of you who don't know, IUI is giving medications and putting in the sperm at the top of the womb, shortening the journey the sperm has to make to get to the egg at the time of ovulation. You trigger ovulation. Cliff notes. It's hard, if everything is working, IUI might kick you up by some percentage points, but not a huge amount. We have one marker of the ovarian reserve there, and it's low. The other marker of the ovarian reserve, which is really vital, is the antral follicle count, is looking at the ovaries and looking at the number of follicles. What I would suggest is, if there's two things here. The first is, if you're going to do fertility treatment, the sooner you do it, the better off you are. You need to make this, you need to get a decision. Sorry, you need to make this a wall or a door. Either we're going to go for it or we're not. And if you're not, that's fine, no problem at all. But make that decision. Don't dally in the decision. Make the decision. The other thing you could consider doing is try IVF, but if the response is poor, if you get 3 or more follicles, great, we'll progress to egg collection and give you a shot, and it's worth trying. If there's no follicles, obviously we'll cancel the cycle. If there's only 1 or 2 follicles, you have the option of converting that IVF to an Iui cycle. And there's obviously financial implications to that, because if there's only 1 or 2 follicles and the other bits are all working, then your chance of success with Iui are probably the same as with IVF.
Okay. So just a question on, yeah. I'm just not sure if that's relevant. Okay. So I'm going to move to the next one. No, it's nothing about your hair. Don't worry.
I was hoping that's right.
Do you recommend reducing your time at work during fertility treatment?
Not particularly, no. I think modern fertility treatments need to work around professional people's schedules. There's no real good data that stress or high work environments negatively or positively impact pregnancy rates. Now, the time after an embryo transfer, some people want to take it easy. Some people go out of their minds at home. So if you have the time to take without compromising your career, then it's very reasonable to think about taking some time off. Don't take time off during stimulation. I've had too many people over the years who've blocked out that entire month to do IVF, and then their bloods come back or their scan is wonky, and you're saying, yeah, we're not going to go this month, we're going to go the next month. I go, but I've taken all this time off. What stage you work your biology here? So you'll need a day or two off for an egg collection, and after that, after the embryo transfer, is up to you if you want to take a few days. After that is common sense stuff. That's not the time to move the piano or landscape the garden. You know, just take it easy. But activities of daily living are fine. You're not an invalid. Okay.
How does BMI affect fertility?
Okay, so badly. If it's high, and not great if it's too low either. So the three most important independent factors for success rate in fertility treatment or spontaneous conception are age, ovarian reserve, and weight. So age and ovarian reserve are things you can do very little about. There's no tablet you can take which makes more eggs appear. At the moment anyway, your age is only, sadly, all of us only going one way. That's how it goes. The one factor you have control over is BMI. So if your BMI is high, working to get your BMI down as part of your workup for a cycle makes your chance of success higher. It makes accessing your ovaries easier. It makes pregnancy easier and lower risk. There's really no downside to that. Equally, if your BMI is dangerously low, you mightn't have enough of your own estrogen, your cycle may have stopped, and we can kickstart that, but obviously you can do that yourself by putting some weight on. Obviously we see more of high BMI than low BMI. You have to try to balance out age and how long you've been trying to conceive. I'm not of the school of thought that says, go away and lose 20 kilos and don't darken my door again till you have.
Yeah, so there's not like a magic number.
No, there isn't. But people need to be respectful and cognizant of the risks that come with fertility treatment and pregnancy in the context of a raised BMI. And there are risks. Now, we don't sail close to the wind. We want to be safe and we want to be responsible and ethical practitioners. So it's not in my nature to start turning people away, and I don't want to do that, but I will have a free and frank exchange of views.
Just be very honest.
You have to be. It's too big not to be.
Yeah. Okay. Trying to weigh up our next steps after 4 failed IUIs.
Okay. Well, so IUI is great, he said, not believing that IUI is great, but offering it. The biggest downside of IUI is that if it works, build us more, we're all delighted. If it doesn't work, you're in exactly the same situation as you were before you did it. You don't learn anything. So we've no diagnostic information about the egg quality, about embryo quality, about responses in terms of, if you've done 4 IUIs, your chance of success with IUI going forward is now diminished, statistically speaking. Now, depending on circumstances, IVF is a very, very reasonable thing to start to look at.
Okay. Would you recommend IVF over IUI for someone with, no, I can't really pronounce this, but maybe you'll know what it means.
Antiphospholipid syndrome. Yes.
You can hardly say it. Yes, but yes, that's it.
Yeah, no, I get it. APLS or APS. So antiphospholipid syndrome can cause miscarriages. So IUI or IVF isn't going to tackle that in any particular way. IVF is a faster way to get pregnant. It's a faster way to have a miscarriage. It's also a faster way to get across the line and have a baby. So as a general rule, look, and this may answer a few questions. The less time you spend engaged with fertility services, the better off you are. All right, that's just fact. So go in, work hard, get out. And that steers me more towards IVF than IUI.
Okay. Can you get baseline scans, bloods in your own doctors, get the results sent to the clinic?
Yeah, sure. I mean, if you can, now a lot of doctors won't do an antral follicle count. They'll do a gynae scan, but they won't do an antral follicle count. If you can find somebody who will do all the tests that we want you to do, external and for geographical or cost reasons, it's better if you do that. Absolutely, we'll take them. Yeah, no question.
Awesome. Is there any way to boost your AMH?
No, is the short answer. The longer answer is there's loads of tablets, like things like DHEA or taking the AMH at a different point of the cycle, which has been shown to maybe make the value go up. Does it suddenly create extra eggs? There's no evidence of that, unfortunately.
Okay. 38 years old, how to improve fertility after a miracle baby, after a cancelled IVF?
Congratulations. We like that. Be proactive, go again. have a look at what worked in the past. Don't let the grass grow under your feet. Be the change you want to see in the world. Why was the cycle cancelled? Was it reasonable to cancel it? Is it possible that you just need ovulation induction or IUI and you can try IVF and throttle back if things aren't working? If you want to have another child, focus and dedicate some time and effort to doing that for a defined period of time.
Make a plan.
Yeah.
Will past unexplained infertility affect future fertility?
Yes. I mean, it's part of your history, isn't it? So the best predictor of future success is previous success. So the longer you have unexplained infertility, that is, say you've had the tests and everything is working, then it starts to speak to some qualitative issue, either with the sperm or the eggs, and more likely the eggs. Okay. So if everything's normal and we've been trying for 20 years, that's a red flag for me. It doesn't mean it can't work, but it's something you have to be respectful of. Okay.
Another question about, will people need to repeat tests, sperm, bloods?
Again, if they're current, that is in date within a year or thereabouts, and it's what we're looking for, then no.
Is there one of the bloods that you have to get done?
So if you're going through treatment, it is a legal requirement that you have HIV and hepatitis screening before we can bring your eggs or sperm into the laboratory and process them. So as part of an Iui cycle for males or part of an IVF cycle for both genders, you need to do HIV and hepatitis. Yeah. That has to be done in our clinic. It has to be done within 90 days of the procurement, the egg collection, or what have you, or the IUI. We can't accept them from somewhere else.
Okay, but most other things
everything
you could.
Else,
yeah.
Else I'm very open about.
Okay. Someone says freeze eggs at 38 or 39. Is that still a good idea, or go straight for IVF for someone who's become a single parent by choice?
So you're freezing eggs because you don't want. So there's a fundamental question here that needs to be answered. Do you want to be pregnant now or not? If you want to be pregnant now, then don't freeze eggs. Try to get pregnant either with IVF with donor sperm or IUI with donor sperm, depending on your circumstances. If you are certain that you do not want to get pregnant now, and you want to preserve the possibility of having a child with a partner that you will meet in the future, then potentially you can freeze your eggs. You are, statistically speaking, a slightly suboptimal candidate because of your age in this situation, but it might be doable. We'll discuss the rates of success, what it might involve. Would you need to do a couple of cycles, things like that? I'll be candid with you, but it's an option. Equally, if you're saying, right, I don't want to be pregnant now, but I want to have a child in a few years, and I don't care who I have that child with, then you could think about freezing embryos, which is perhaps a bit more value, but of course, genetically weds you to the sperm source that you've used for them.
In terms of success rates using frozen eggs and frozen embryos,
it's the same, but it's not. They're potential. So an egg has potential X, an embryo has potential Y. Like if I freeze a perfectly normal looking egg on a 25-year-old, that has a 3.2 to 3.4% chance of turning into a baby. If I freeze a really...
I think people are very shocked when they hear that number.
They always are. They're just thrown back.
People think it's like, 60, 70%.
Yeah, 90 was the last number I heard, which is, that's optimistic. Anyway, it's not. We're not. We're mammals, but we don't have litters. We don't have multiple children. We don't have children every year in the traditional springtime sense. So an egg, 3 to 3.5% chance of giving you a baby at an optimum. A good day 5 blastocyst, now only 40% of your fertilized eggs will turn, 40 to 50% will turn into good blastocysts. A good day 5 blastocyst, and the same person probably has a 45 to 50% chance of turning into a. So if I've got 20 eggs frozen on that person, that's a really good chance. If I've got 3 blastocysts, that's probably a better chance.
Yeah. So it kind of works out the same, but it's
ultimately it's the same bit of material. It's just you've made one of them jump through more hoops.
Sure.
To give you so that you know what's in the freezer has a higher.
And I suppose
value.
When you're freezing eggs, you can't speak to the quality of those eggs, and you can't say whether any of those eggs will actually turn into blasts at all.
You can't speak to quality at all.
Okay. What is the process for switching clinics if someone's unhappy with their current clinic? Is it possible to do?
Yeah, of course it is. So look, switching halfway through is something, I mean, if you have embryos frozen with a clinic, I would genuinely urge you to use them. You've gone to a lot of time and effort to make them, suck it up, use them. Just go through, do the transfers, try to get across the line with them. I'm shooting myself in the foot by saying that, but I think it's the correct thing to do. If you don't have embryos with people, or you have them but you don't want to use them or whatever, then you absolutely can move clinics. Now, what you need to do is you need to get a copy of your notes. The more information you can give us, the more we can learn from the previous cycles that you've had, and use that to build a plan going forward, and use it to advise you as best we possibly can. So they're your notes. Back when I was working in the hospital system, if somebody asked for a copy of their notes, it meant that they were going to take legal action. This is back in 2003, 2004. And crazy, even still at that time, which isn't that long ago, there was a tendency to close ranks and try to withhold the information, which is bonkers. One, the information doesn't belong to you, it belongs to the patient. The patient owns the records, not you. You're just minding them for the patient. And I've completely reversed course on this. When somebody asks for a copy of their notes, this may be your last opportunity to engage positively with that person. And if you can, in a very timely fashion, get them their records, give them all the information in a clear and consumable fashion, and make their lives easier, I suppose there's a little bit of me that goes, well, they go away thinking, are we doing the right thing? Which is, speaking personally, I feel a certain kind of way about that. But also, it's the right thing to do. So we've had a few people looking for records and things like that. When we have your blood results, they are made immediately to you through your portal. When I do a consult, that's published to your portal. When I make a treatment plan, that's published to your portal. So really, get your notes as quickly as possible. Hassle the place to give them to you, and then absolutely good move. Sorry, rabbiting on.
I've been told that scan and stims can start on day 5 of the cycle. Is this normal? I thought it was day 2.
Well, day 1, 2, 3, 4. Day 5 is possible, but it's a little bit, maybe ever so slightly late. I don't know if I'm shooting myself in the foot. Don't know who's asking that.
Did you say this?
Yeah, no, normally I would you look to the circumstance and you see what's the cost. It's now day 5, either we start stims now, or what happens? Well, I'm moving to Uganda next month and I'll be gone for 10 years. Okay, sod it, we'll give it a shot.
Yeah.
Or is it a case of, look, we just won't start in day 5, we'll be able to start in 23 odd days. That's a different story entirely. Yeah. So you got to cut your cloth to fit your measure. It's possible, but it's right on the cusp, because at that point you may have recruited a follicle, it may be getting a little bit bigger than the others, and that will tend to suck up all the stims that we give. And so you might get a suboptimal response, but maybe there's extenuating circumstances.
Okay. I have a BMI of 41. Hubby has sperm frozen. All checks are okay. Would you take us?
Yeah, I mean, I'd have a chat. Let me have a chat. I'll talk to you. What's your age? What's your AMH? What's your ovarian reserve? What do you want? If we do a scan, can we get to the ovaries? Sometimes there's challenges with that. What are the risks of pregnancy? So look, I'll beat you with the stick. I'll try not to shame people. This is me talking. I mean, look, I'm as wide as I am tall. I try not to shame people, because that's just horrendous. And you have to be respectful of the fact that, look, this is somebody who, I guarantee you, has her whole life struggled with her weight. And telling her go away and lose weight is not the solution. You've got to work proactively. What age? Do we have time to get weight down? Do we not have time? Can we get to the ovaries? What are the risks and what can we do? Yeah. Talk to them like they're a human being.
Recurrent early miscarriage, blood scans, all okay. Is IVF the next step? Yeah, potentially. Now, again, wouldn't mind talking to you and seeing what may, depending on history and circumstances, be useful for you. Something we don't do, which is pre-implantation genetic screening. I think you need to be wary of all the other miscarriage stuff, natural killer cell testing, things like that. Doesn't have a whole lot of evidence behind it, but genetic screening of the embryos may be something. Come in, have a chat with us. Like, you'll talk to the nurse, it won't cost you anything. Talk to me, it won't cost you that much. And I'll give you a fair steer, if that's appropriate for you. Do lifestyle changes really increase your chances of conception? Depends where your baseline was. Again, if your BMI was off, high or low, fixing that is good. Simple stuff like binge drinking and smoking, obviously that can have a profound impact on both sperm and egg quality. So you need to be respectful of that. You have to stop smoking. You have to drink intermittently and not huge amounts. After that, healthy diet, sleep, you're pretty much there or thereabouts. Do all of that before you start taking a bunch of supplements. Okay. Is 17 eggs frozen enough for someone with endo, or would you go again?
Ooh.
Have already done two cycles.
So done 2 cycles to get 17. It's not a terrible number. Depends what age you are, I suppose, when they were frozen. Because as I said, if you're 30 and they're frozen, each egg probably has about a 3% chance. If you're 40 and they were frozen, each egg has a 1% chance. So that's a massive difference. That's the difference between a 17% chance of a baby and a 55% chance of a baby, give or take. So there's a lot there. It also, you're talking about one baby. You know, you also have to look at how much it costs to freeze those eggs.
Yeah.
Are you about to have surgery? Do you want more than one child? It's not a bad number. The number we tend to pluck out of the sky in terms of, oh, that's enough eggs, is 17. But we've pulled that out of the sky, and everybody's an individual. And how difficult did you find it? How easy it is for you to go again? More is better than less, I guess, you know?
Okay. We have so many questions to get through. You're gonna have to start talking less. Just gonna be really hard for you.
Yeah.
Okay. This is a nice one. Did a round with John in his previous clinic, have a baby boy.
Hey.
If I go to therapy, can I get the same protocol?
Don't know what protocol you were on.
CAAP, gonals.
No, cap protocol. Yeah, we're not running cap. I've looked at all the data. I don't think it's a bad protocol. It's a bit clunky. It takes a lot longer. When we built our processes from the word go, did a deep dive on all the evidence, did a deep dive on all the outcomes. It just statistically hasn't been shown to improve things. Or is there a couple of edge cases where maybe it's of benefit? Potentially, yes, but it's so clunky and complicated that we're not doing it. So I don't want to overpromise and underdeliver. I won't do a cap protocol. Do I think you need a cap protocol? That's a bit more controversial.
Another controversial one, opinion on Chicago bloods, and do you do them?
Don't do them, don't like them. Used to do them a lot, don't do them anymore. No evidence of benefit. You read down at the bottom of the page, it goes, this test is not licensed by the FDA. That should tell you something, I suppose. There is no evidence that the treatment of raised natural killer cells with any of the treatments that are currently out there, be it steroids, interlipids, plaquenil, hydroxychloroquine, LIT therapy, anything has an impact in any meaningful way on live birth outcomes.
Okay. What could cause a frozen embryo to not recover from the thaw? I'm heartbroken.
That's really upsetting. So with the new vitrification techniques, thaw survival rates are really, really high. We quote 98, 99%. We have had one embryo so far. Kills me. Failed the thaw. But we thawed obviously loads and loads of embryos, even in the short time that we've been open. So it's heartbreaking. What you tend to say is if an embryo, a freeze and thaw cycle is a bit of a stress test for an embryo. So what I've always tended to say is if the processes are good and the lab knows what they're doing, which I think they do, then it was a stress test for the embryo. And that's, I think, the most honest thing you can say.
Okay. As someone with Crohn's disease, will that lower my egg count due to meds? I'm 35. Good
question. I don't think so. The short answer is probably not.
Okay.
Get it checked, but probably not.
Okay. Could a person with one follicle on each ovary potentially produce more than 2 eggs after the egg retrieval meds?
So you can you've got your 2 big follicles, you go after them both, then you try to leave no men behind, you go after all the little follicles. Sometimes you get eggs from them, but they're less likely to be mature. You won't get 2 eggs from one follicle, at least we don't think so.
Okay. With a high AMH level, having PCOS, what alternative tests are available to inform a woman of her ovarian reserve?
It's the same deal. It's AMH is antral follicle count. That will tell you your ovarian reserve. It doesn't matter if you've got a PCOS, diminished ovarian reserve, premature ovarian. That is the test of ovarian reserve. That information will also tell you, to an extent, the degree of PCOS that you might have.
I have 2 boys aged 18 and 17,
okay.
and I'm now on my 6th consecutive miscarriage.
Oof.
I've had karyotyping and is that how I pronounce it? Thrombophilia screen done, and both came back normal.
Okay, so it's reassuring that those tests came back normal. It's unsurprising. They usually are. You have a child who's 18, you have a child who's 17. Realistically, if you started when you were 25, that's, so maybe it's age related. I don't know. And if that's the case, then it's more treatment with a high rate of miscarriage. It's genetic screening of the embryos, but that's controversial because it doesn't increase your overall chance of success in these circumstances, or it's potentially alternative sources of eggs. I don't have enough information there, so that's kind of sweeping. I don't want people to get upset. Maybe have a chat.
Okay. Unexplained infertility after 2 early miscarriages over nearly 10 months. I'm 33. All tests are normal. No AMH sperm issues identified. Is it time to start IVF?
I don't think so. I think you've had 2 miscarriages, and that's really, really unfortunate, and it's horrible. It means you're not infertile. That's if you're looking to take something away, some positive away from this. So I would say keep trying. You've had your tests. Maybe that they had recurrent miscarriage investigations. Probably, yeah. If that's reassuring, then that's great. If they haven't, then maybe think about getting them done if you can. Just tick the boxes and keep trying. I wouldn't necessarily go foisting fertility treatment on you just yet, because it won't reduce your risk of miscarriage in and of itself.
Okay. What happens if you've done a frozen cycle and your period does not come?
It's a trick question.
It's not a trick question. I assume it means.
Are you pregnant?
No, I assume it means if you're timing for a frozen embryo transfer.
Okay.
And you're trying to time so you can take the.
So you're
meds.
trying to start a frozen embryo transfer cycle, but
I
your period hasn't come.
I think so. Yeah.
Then generally, contact your clinic, get a scan, see what the lining is looking like. See, do you need to induce a bleed or start the? So what needs to happen to get you into the cycle? Yeah.
Yeah. We're not trying to trick you.
No, it's like I did fertility treatment. My period never arrived, and I'm getting fat. I don't know what's going on. Okay, I got a thought.
I'm 40, trying for my second baby. AMH is high, 30 something, but have had 3 miscarriages since March. What would you advise next?
Tough. So time is a factor here. I would think fertility treatment is reasonable. I think IVF is reasonable. If you want to front load your costs, you can consider genetic screening, but you're adding a lot of cost to the front end without ultimately increasing your chance of success, but potentially reducing your risk of miscarriage on transfers.
Okay.
Yeah, but at age, consider doing something.
Okay. Will reducing BMI improve the quality and motility of sperm?
Yes.
There you go. Would low iron affect chances of getting pregnant during IVF?
Not really. Not if your hemoglobin is normal. I mean, if you've got low iron, take supplements. Take an iron supplement by all means. But if you're not anemic, then your body's compensating. You can just build up the store again.
Okay.
See, I sped up, and now I'm waiting on you.
Well, I'm trying to make this text bigger. I had so many questions that I can't even read my own writing here. Okay, another one. 45. What is the chance of fertility treatment working?
It's low. Depending on history, it might be worse or better, but you're probably talking 0 to 5% live birth rate in some way. The challenge is I'm going to go into this in very quick detail. One of the challenges here is if you get people that age who have a healthy ovarian reserve, you get lured into thinking, oh, we can get eggs, but the chances are still low. So there's a trap there.
Okay. How low is too low in terms of AMH?
Look, it's only one marker of ovarian reserve, so you twin it with the antral follicle count. It doesn't speak at all to your chance of spontaneous conception. I've seen people with AMH of 0.4 spontaneously conceive if they're younger. So it's one piece of the puzzle. It's a good jumping off point. It's not the be all and end all.
Age 38, have a 4-year-old, trying for a second baby. Had a miscarriage 14 months ago and no luck since. Are the chances higher in IVF if you have a child already?
Yes. The best predictor of future success is previous success. It tells us certain things are working. But of course, the longer the passage of time between having the child and trying to go again or doing fertility treatment, perhaps slightly less relevant that becomes. But in that history, given everything that's happened, now's the time to think about what you're going to do. Okay.
Failed IVF cycle in the past, possibly egg quality problems, PCOS and high BMI. What can I do to help before another cycle of IVF?
Look, we've answered this question. Get your BMI down. Now, people with PCOS struggle to lose weight. All right. It is genuinely harder for them. The fat sticks to them. They can't shed. It's not impossible, but it's definitely harder and it's definitely a slower burn. But anything you can do to get your BMI down is a positive thing. If you're young and you have time, then that will yield tangible impacts. So that's where the focus needs to go. Things that we know, don't crash diet, make small sustainable changes to your diet, exercise, but it's 70%, 60-70% diet, 20-30% exercise, and the rest is sleep, so, or even sleep and then exercise is actually a small bit. If your diet goes down, you will lose weight slowly. If you can get some exercise, you will accelerate that process and also improve your cardiovascular fitness. Good for pregnancy, good for everything. That's the single biggest thing you could do.
Okay. Again, BMI, do you have a BMI cutoff?
No.
Age 38, have lost 6 stone. Well done.
Wow,
that's amazing.
I mean,
but I know age is on my side.
So we celebrate that. You're trending in the right direction. You've made all these changes in your life. If we can get access to the ovaries and we can have a real conversation about the risks and you're accepting of them and it's reasonable, we're all on the same page, then this is exactly the kind of case that you want to support.
Okay. Can you do virtual appointments and then pay local clinics for checks and tests due to location? So, I'm assuming
yes,
you do the consult. Yeah.
Yes.
So they can do consults.
They can, if online. They can find someplace that'll do them. That'll do the test, do the AMH.
But the virals, they have to come.
The virals, they have to come to us. And also a lot of people say, oh, yeah, we'll do an AMH. And then a month goes by and you find out that they didn't do it and it turns into a whole thing.
Okay. I'm on the pill for 12 years, came off 26 months ago, trying to conceive, however, haven't been successful. I'm 31, husband is 32, went to the GP for bloods, all appeared normal. Should I go for testing at this point or what would be suggested? Yeah,
go and get tested. Go and get tested. The pill, being on the pill that long should be protective for ovarian reserve, not detrimental, but go get checked. Let's have a look at the tubes. Sperm's been done. Let's check an AMH if it hasn't been done. AMH, housing tubes, and then talk about options.
Okay. Can anything be done to improve sperm motility?
Yeah, so I mean, some sperm, I'm going to start talking now. Some people have really sensitive sperm, sensitive to lifestyle and dietary changes and environmental factors. Some people have bulletproof sperm. So if you're smoking, stop smoking. If you're using recreational drugs, especially THC and marijuana, stop that. That can have an impact on motility and DNA fragmentation in sperm. Alcohol, especially binge drinking, more than 2 pints is a binge. Sorry, everybody. And trying to maybe get weight down, and maybe even just repeating the semen analysis might show better motility next time out. Who knows? Okay.
Last 2 questions. High thyroid levels post-COVID. Once corrected, how long do I need to wait to start IVF?
I mean, we need to see how high is high. I think fertility clinics have for too long been far too regimented and strict about where thyroid needs to be to proceed. I think we have a little bit more flexibility there. Is it trending in the right direction? We also know that fertility medications can play merry hell with thyroid. So it's a balancing act. Get them checked. If it's not bonkers, you proceed. You can certainly do cycle and freeze the embryos because the impact of the thyroid will be on implantation, not on egg quality.
Okay. Last question. What if a partner has a Zoospermia?
Okay.
What are the chances of him being the genetic father of a child through IVF?
It's not impossible. So Zoospermia, what is that? It's no sperm in the sample. So why is that the case? So the first thing you would do is you would repeat the sample. Is it true? Is it not? I've seen 0 go to hero across 3 months because of viral illnesses or what have you. I've seen it go normal. Then if it's 2 samples and they both have no sperm, you got to work out why. Is it obstructive? Is it not obstructive? Is it a problem with production, warehousing, or delivery of the sperm? So you do bloods, you do ultrasound, and then you see, right, if we aren't getting any sperm out in an ejaculate, can we get sperm from the testes? If we can get sperm from the testes, then it's on. We can do ICSI. If we can't get sperm from the testes, can you do a micro-TZ, which is a more involved way of getting sperm from the testes? If we can't do that, then yeah, you're looking at donor sperm. But there's a lot there. You got a whole big road to go down. So don't freak out now. It's only day 1.
Okay. Cool. Well, I think that's most of the questions answered just in time. Thank you so much to everyone for joining us. Thank you for sending in the questions. Again, if you have any questions or if we didn't get to answer your questions, please do send them in to us and we'll be happy.
We'll do something. We'll get it out to you. I mean, it's fun to answer.
We're not too bad at making these videos, so John loves
I get told what to do, where to go and what to say.
But thanks again for joining us this evening. We really do appreciate it. Remember, we do have our podcast, Fertility Talks.
That's
right. And make sure to sign up to our newsletter so we can inform you of our next webinar in March.
That's right. Perfect.
We hope you've enjoyed this evening and thanks again for joining us. Thanks, John.
Have a great evening. Take care.